Okay, well, welcome to the COVID-19 What We Know Today by the International AIDS Society. And today is all going to be about addressing questions about COVID-19. So we will actually ask ourselves a couple of questions and then we will move on to just take questions from you, which you can enter into the chat. Next slide. Okay, well, this is the time I think we can address questions, a couple of questions to each other based on the questions that we got ahead of time from people who registered for the conference.
Sure, I'll kick things off.
Okay.
So I'm going to ask you the first question, which is, can you help us understand aerosols, droplets, fomites, what's important, what's not in COVID-19? Inquiring minds want to know.
This is a very good question, and I have tried to figure out how to frame it to both laymen and to people I'm talking to at work, because I think it's been a very interesting evolution. I think that at the beginning of the COVID pandemic that we had no idea why it was spreading so fast. So SARS, its cousin had 8,098 cases and then it was done. And this was supposed to look just like it, and then it kept on going up and up and up. And so why was it spreading so fast? And I think fomites got in the mix, and surfaces, and so many different theories. And really the real reason is because even if you feel well, you can spread it and you can shed from your nose and mouth at quite high rates. So in terms of fomites and surfaces, and then we can do the airborne and aerosol and droplet, you can culture viruses from surfaces, but those studies cultured it from where they put a lot of virus on a surface. I mean, you can't get that type of virus on a surface except if like 100 people sneezed on that surface. So I think it's very reassuring to say that in this technological age, we can culture things from a number of different surfaces and toilet bowls and everything else. But luckily, it does not seem that fomites and surfaces are a major route of spread. And in fact, the CDC and I think Scientific America put this out, and this is now being called the myth of COVID, which is helpful. You don't have to sterilize your food. You don't have to sterilize all your grocery bags. You can touch things in the store. And I think that's really helpful to have that gone, that particular aspect. But I think the aerosol and droplet and airborne is harder. And the way that I've really tried to understand it is that I think it's both. I think that SARS-CoV-2 gets carried along in droplets that are usually big and have saliva in them, and so they're bigger particles. But it is true under certain situations, especially if you're forcefully singing, for example, or doing something that can expel out the virus, that it can stay in the air for longer, and that makes it more along the lines of smaller droplets, which were the definition of airborne. However, I think that when we go back to definitions, we as infectious disease doctors and epidemiologists had different definitions than physical scientists, and to get on the same page, we used to think that airborne meant it was like measles, and it's not at all like measles. What I mean by that is measles is very contagious. It hangs in the air, and one person can infect 15 people. SARS-CoV-2, one person can infect 2 to 3 people at its worst. And so it just is not as hardy as measles. It actually hangs in the air and then falls to the ground. So I would say it's a mixture of both. And because of that, it's almost like a mixture of recommendations. We would not be recommending masks if we didn't think that, surgical masks and cloth masks, if we didn't think it blocked out a lot of the viral particles. And on the other hand, we would not be thinking that outdoor and indoor make a difference if it was totally airborne. So we had to do a mixture of recommendations. And where we are now is that indoor settings seem to be more risky because they don't have the ventilation. So you want ventilation, which is why schools or installing ventilation or air filters if they can't have the windows open. And outside is better than inside. And masks, even surgical masks and cloth masks absolutely work. So think of it as I think a hybrid of the two.
Great. You know, the point you made about measles is a really good one. I had a case some years ago where a person got measles just by walking by another person in the airport. The one person was deplaning, the other person was getting on, and that person caught measles. And this is not really like that. It's not, you know, it's not so transmissible that's going to happen. So
I think that's an excellent way to think of it, because it makes you feel less scared, and it's why close contact is defined by a certain amount of exposure. CDC says 15 minutes within 6 feet, because it does, and maybe that will change so it's a little less, but it certainly isn't walking by. And so I think that gives it less of an aura of, it doesn't spread as rapidly, it's not as transmissible, and that masks absolutely work because droplets are quite big, and it usually is in droplets.
you know, what got a lot of press not too long ago was this question of fecal aerosols. Do you want to say anything about toilet bowls and fecal aerosols? Can we decide together that that's rare?
Yeah, let's please decide together, not just because it's gross, but because it's again the culture of like, where is it most transmissible? That is really not where things seem to be happening, and it really is. It's actually not that hardy of a virus. The measles RNA virus is quite hardy. It's just not that hardy to sit with things in a bowl, and so it really has to be kept moist, and it has to be kind of directed at you. That is why it's helpful to know that the reason it started spreading so fast is just like measles. It can spread from your nose and mouth even when you are asymptomatic, and that is what makes it so different than influenza or SARS. That influenza, you feel sick when you spread it from your nose and mouth, and SARS, it replicated mostly in the lower respiratory tract. So I wanted to ask you, because you know, we have not been in San Francisco, had the number of cases that you all saw in Boston, but so we think of treatment a little more theoretically in the sense that you really experienced it. And last time when we were on together, we talked about treatment, but we talked about severe SARS-CoV-2, and we didn't actually have a lot of some of this data. And I wanted to ask you both if there are updates on severe COVID-19, but also what about all these people coming in with more moderate disease? Because that's that confusing part. You know what to do if they're intubated maybe, but what do you do when they're not so sick and they're on the floor?
Yeah, no, I mean, no, we all remember March and April where we really didn't know, even the faintest how to treat severe disease. And what we can say now is that we do have 2 drugs that do work against severe disease. Just with a couple of definitions, I think, as you said, for aerosols and droplets, that's important. Let's talk about definitions for severity of disease. So 80% or more of COVID-19 is mild or moderate, and we'll talk about some new data for moderate. Severe disease is about 15% or so, at least early data out of China. And what does that mean? So severe disease means you're essentially have hypoxia, you have an O2 sat less than 93%, you need supplemental oxygen, or you've got pulmonary infiltrates, or a lot of pulmonary infiltrates. So we know now that remdesivir decreases the time to recovery in people with severe disease. It has its clearest benefit in those people who are on supplemental oxygen, but aren't yet on mechanical ventilation. And back in May, an emergency use authorization was issued for remdesivir, and there was an update recently that we'll talk about. We also know that dexamethasone reduces mortality, and its greatest benefit is in those people who are on mechanical ventilation. There is also a benefit in people who have severe disease who are not yet intubated. So what's moderate disease? So moderate disease is when you've got clinical and radiographic evidence for lower tract infection, respiratory infection, but you don't have hypoxia. Your O2 sat is 94% or greater. And I had a patient just like this about a week ago. And the question was, what do we do? So just a couple of weeks ago, the FDA actually expanded the emergency use authorization for remdesivir to include people who were hospitalized with all severities of disease, including moderate disease. So what's the basis of that expansion? So in JAMA, not too long ago, there was a randomized trial published of about 600 people who had moderate COVID-19. They had an O2 sat over 94%, but they had evidence of lower tract disease. And they got randomized to standard of care, no remdesivir, 5 days of remdesivir, or 10 days of remdesivir. And what that trial showed is that the 10 days of remdesivir versus standard of care, really no difference. But the 5 days did have a improvement in clinical status, but it was relatively modest. In fact, the authors themselves wrote that it was of uncertain clinical importance. In all the groups, the mortality was low. Moderate disease is much less likely to lead to complications. There was about a 1 to 2% mortality, so nothing like severe disease. There were no data really on long-term outcomes or things like return to normal activities, things that are important to know. And what I would say for now is I would make a case-by-case decision for people with moderate disease. We admit them to the hospital somewhat less than we did back in April. Sometimes we follow them at home. But if someone has a lot of risk factors for deterioration, they're very aged, they're very immunocompromised, then I think remdesivir is a very reasonable thing to use in someone with moderate disease. And someone who's young or has very few risk factors, then I think often they will get better without any particular intervention. The next thing I'll mention that's relatively new, we don't have all the details, but there was a trial that there was a press release on from Lilly for an antibody looking at mild to moderate disease. So now we're shifting from those hospitalized patients really to outpatients. So you may have heard about this antibody. It's an antibody against the spike protein. That's what allows the virus to get into cells. It actually was identified from the blood of one of the first US patients with COVID-19. And what they reported, and we don't have some key details, so just keep that in mind, is that they had a placebo-controlled trial. They had 3 different doses of the antibody, low, medium, and high dose. And what they said is that the medium dose actually reduced the amount of virus at the primary endpoint date, which was day 11. Now, when they looked at the other doses, it appears that they also had an effect, the medium, high, and low dose at earlier time points. And remember, a lot of people with COVID will resolve their virus in the upper respiratory tract by day 11. The thing that was kind of tantalizing and got a lot of attention and something we should watch is that the rate of hospitalization in the people that got the antibody was lower than in the placebo group. It was 1.7% in the antibody groups and about 6% in the placebo groups, but the numbers were small. So it's something that's tantalizing, but we really need to know more. And the other type of things we need to know more about is were these groups balanced? How long had they been sick? How severe was their disease? There is an ongoing study in San Francisco at UCSF. There's a study, multiple sites around the country through the AIDS Clinical Trials Group, NIH funded, called the ACTIV-2 study. And that's using this very same antibody. And I think if the results are borne out, what it means is you can use an antibody to have an antiviral effect. And whether that's clinically meaningful, time will tell, but it does look promising. Let me just say one word about 2 other things that have been in the news a lot. One, of course, is convalescent plasma.
Right before the Republican National Convention.
Yes, August.
The day before.
Yes, the eve of the convention eve, August 23rd, a day that will be remembered. This convalescent plasma emergency use authorization that the FDA issued that day was really based on data from a expanded access program run by Mayo Clinic. And this was the rationale that was presented. They said they compared outcomes among patients who either got a high titer of the antibody or a low titer of the antibody. Now, they did this on a subset of the people. They did not have the titers before they gave the convalescent plasma, but they had saved the plasma, so they went back later and they looked. And what they found is that among non-intubated people, the people who got the convalescent plasma that had a high titer had a 11% mortality, and the people who got a low titer had a 14% mortality. So there was a difference in mortality if you got high titer versus low titer. And with some other analyses, it looked like if you got it early, within 3 days of diagnosis, with a high titer, you also appeared to benefit. But notice this was a single arm study. It was an expanded access program. Every single person in that study or that program, really a program more than a study, got convalescent plasma. It was just a matter of when did they get it and what was the titer. And so what the NIH treatment guidelines panel and the IDSA really concluded is that because there's a lack of a comparison group, because there could be confounding, it may be that if you get a low titer, you actually have a deleterious effect, that really convalescent plasma should not be considered standard of care. And if you look at the FDA EUA, they actually said the same thing. They said that you should not consider convalescent plasma standard of care. And we just got to complete those randomized trials. Those are the same trials, types of trials that got us to where we are with dexamethasone and remdesivir. So that's what I would say, and I think what a lot of people would say about convalescent plasma. And maybe the last thing I'll comment on, and then obviously there's much more to say, but I'll just leave it at one more topic, which is tocilizumab. Keep your eye on tocilizumab. We don't know all of what we need to know about this, but more information is coming. So if you scroll back in your mind all the way to March, we know that interleukin-6, if you have higher levels of interleukin-6, the clinical outcomes tend to be worse. This is this so-called cytokine storm. And there were some early non-randomized trials suggesting benefit, but not definitive. And we know that observational trials can be confounded. So 2 trials have come out, one in preprint, one as a press release. That seems to be how a lot of these treatment trials come out. The preprint is a trial called COVACTA. It's a manufacturer-sponsored study. And that was a randomized trial in about 450 people, severe COVID-19 pneumonia. So now we're back to severe disease. And they said there was really no difference in clinical status and no difference in mortality in the tocilizumab group versus the placebo group. There were some differences in duration of mechanical ventilation and time to hospital discharge, but no mortality difference. Just last Friday, another press release came out, another manufacturer trial called MPHG, so a different trial, also randomized, also phase 3. Here they looked at, I think, a little bit less ill population. They were all hospitalized, they all had hypoxia, but they could not be mechanically ventilated, and that may be a difference. We don't know the details. One thing I would applaud about this particular trial is they made a concerted effort to enroll underserved and minority participants, about 90% of them. And so their headline in their press release is 44% less likely to progress to mechanical ventilation or death in the TOSI group versus the placebo group. But again, no difference in mortality, no difference in clinical status. So time will tell. I think we just need to know more about these trials and really make a determination. Personally, I would not use tocilizumab yet outside of a clinical trial, but something to keep your eye on.
And maybe since we have steroids, we have to figure out like beat the balance between those two if it does get approved, because it really is the anti-inflammatory. Okay, thank you so much. That's really helpful to know. We've come a long way though. So that's good since the last time we talked.
And one of the critical things is how do we combine these? Not a lot of combination trials have come out yet, and that's going to be, as it was in HIV, I think a really big part of treatment is combinations. And so once we get active agents as monotherapy, then we need to do combination trials. So also in the news, a lot has been these reinfection cases. So what do you think about these reinfection cases? And what do you think they tell us about immunity? And while we await a vaccine, what kind of things should we be thinking about as we think about both reinfection and immunity to COVID?
Well, I think that I think that they don't. I think that they've been in the news a lot, but they are not that frequent. So I think they got a lot of attention. There was a case from Hong Kong where a patient, had to be retested as part of a screening and had it again, and it really was a different look. It was a different genomic variability, and so it was a reinfection, but it was part of screening and he actually was totally asymptomatic. And then there was another case in Nevada where the second time around the patient was more symptomatic, different reinfection. And then there's some, I think, being rumored and coming out from Europe, a couple, maybe 2. with this many infections, over 31 million and counting, and the fact that SARS-CoV-2 now has been with us since November at least, it actually is more of the exception that proves the rule, in the sense that it does look like immunity. We would be seeing many, many more reinfections most likely if we didn't have some immunity to SARS-CoV-2 after natural infection. And I think sometimes because the media has been such a big part of this, and the media likes antibodies because they're easy to say and they're easy to measure. So there's a lot of seroprevalence studies that may or may not reflect exactly what's going on. So just our reminder, because a lot of these people on the call today are HIV people, so we definitely think about T cells a lot, but sometimes the media doesn't. When they report on things, that really just to explain it the most simply is there's two arms of the immune system. There's the humoral response and there's cell-mediated response. Even before that, there's the innate immune response, where you just are very non-specific about your inflammatory response to viruses, and that's why sometimes you have to calm it down. If immunopathology has a big role to play, like with steroids, if there's a very disorganized and bad immune response, there's too much inflammation. But the adaptive immune response is really two arms, the humoral and the cell-mediated. And then the cell-mediated response can be divided into B cells and T cells, and then the T cells we know are divided into CD4 and CD8 cells. And when we just say antibody, which is the humoral response, and do those antibody testing studies where 5% of people in Madrid have antibodies, or 60% of people in Queens, or I think healthcare workers have a very high rate of antibodies, actually a CDC study on September 4th. It doesn't necessarily tell us the extent of immunity to an infection, because antibodies can come up and they can come down, and there's neutralizing antibodies. And there was a study in the New England Journal from Iceland that maybe they can stay up for 4 months, but it doesn't mean that's it represents the entire immune response. And so I think the fact that we've had so many papers now in the last 6 weeks that show good T cell responses, really strong T cell responses, and memory T cells and memory B cell responses to SARS-CoV-2 is very hopeful. It's hopeful for some immunity to this virus while we're waiting for a vaccine. I don't actually know how long, and I don't think anyone knows how long, because we can extrapolate from other coronaviruses and not say it's lifelong, but we don't know. This is such a different virus than SARS that we don't know how long it's going to last. And of course, we need a vaccine. But if it could tide us over till then, or if it also gives us hope about vaccine development, then I think that's hopeful. So I think that these reinfections are rare. I think that there could be a bunch of them occurring that are asymptomatic, which is why someone doesn't get swabbed again and even checked again. And actually having an asymptomatic infection is sometimes a sign of having developed memory T cells so that you wall off the infection really quickly. So it could be that reinfection is much more common than we think. They're asymptomatic. It indicates some natural immunity, and I think that gives a very good sign for vaccines. And I think that we hopefully will get to a vaccine, and a vaccine probably has to elicit something deeper than just an antibody response. So that's how I would say that the reinfections got much made of, but I'm not as worried as the press seem to worry about it.
You know, one thing that I think is really interesting is that even in people, if you took their blood well before COVID-19, some people have these cross-reactive T cells. That is, they have T cells that recognize SARS-CoV-2, probably from a prior seasonal coronavirus. And do you think that those might be, you know, seeing SARS-CoV and might explain a little bit about why there's so much difference and why some people get so ill with COVID and other people don't?
Yeah, I think that's such an excellent question, because I think, you know, there's 4 seasonal coronaviruses, and then there's the SARS and MERS, which both cause really bad disease. But if you have some T cells that are cross-reactive against SARS-CoV-2 and you would develop them in response to cold, could it be that you're walling off or fighting that infection before you get too sick? And that has been implicated, like you said, in why is there such variability? Why do some people totally fine and some people totally sick? Like Dr. Fauci always says, this protean I like this word because my child just told me who Proteus was, but like this protean manifestations of disease that some people are totally fine, and you just said it, some people are really sick. And so could it be partially that we're almost getting an asymptomatic infection because of this cross-reactive T cells? This has been implicated in what's going on in sub-Saharan Africa and India, where the case fatality rates, India is taking off, but the case fatality rates, it could be that we're missing a lot of deaths for sure, but and I hope not, but I do think that it's been implicated that could there be in sub-Saharan Africa and India not the degree of fatality that we thought, because maybe there's less severe infection because of exposure to other viruses, other seasonal coronaviruses. I think it's very intriguing. It also makes me worry about doesn't make me worry about the vaccines, but I think deeply about the vaccines. If you have a piece of RNA or DNA or spike protein, are you going to be able to elicit the complex immunity and the T cell immunity that you need for more durable immunity? Or are you going to elicit an antibody against the spike protein or against the RNA of the virus, and it's going to last for a while, and then you're going to need another dose? Or, so it's hard always for us to get the complexity of the immune system unless it's a very simple way, and this is not a simple virus, I think. Like in the way that HIV was so unsimple, like HIV, a vaccine has really eluded us because it's so complex for a vaccine. So this does lead me to vaccines. I think there's also been a lot of media about vaccines, and it's so complex right now to hear people who shouldn't use the word vaccine say vaccine so often. But I think it's what do you think about timing, the number of candidates we have? Are you feeling hopeful? Were you worried about the latest vaccine trial that had to stop and is still stopped in the US? So what are you thinking about vaccines? Because I know you think about immunity a lot.
I am optimistic about the vaccines in terms of having an effect. As to whether they'll need boosters or how long they'll last, I think we just don't know. I am most worried about the politicization of vaccines, as you were alluding to, but let's for the moment stick with what we know about where they're at. Hundreds of vaccines are being evaluated. There's a number of them now in phase 3 trials. I would say there's 4 trials as of this morning to keep your eye on, big phase 3 trials. Phase 3 trials, of course, are looking at, do the vaccines work? Are they safe? And if they work, how long do they protect against infection? And people have been appropriately saying, we just don't want to prevent mild infections. We want to prevent those severe infections. And just today, the FDA, there's reports about really making sure that the vaccines are preventing the type of infections that we really want to prevent, which are severe infections, or at least if it's not preventing severe infections, it's got to prevent transmission, and that's a trickier thing to really get at. So where are we with the vaccine trials? I'll just say a word. I think everyone is following these. The one or the two that are furthest along are the Pfizer and the Moderna vaccines. The Pfizer is in connection with a German company. It's an RNA vaccine. It's being tested in the US and Germany and Argentina and Brazil. This is the one that you probably read about recently, where they went from 30,000 up to 44,000. One thing to remember about the Pfizer vaccine is it's a 2-dose vaccine. And when we get to the last vaccine, we'll explain why that's important. And those 2 doses are about 3 weeks apart. The other one everyone is tracking is Moderna. This is also an RNA vaccine. Now remember, RNA vaccines haven't yet come to fruition. These would be the first. About 26,000 of the 30,000 people enrolled as of a week or so ago, and they say at least that 29% of them are from diverse backgrounds. This too is a 2-dose vaccine. The one that raised some concerns and that is currently paused in the United States is the AstraZeneca vaccine. This one is not an RNA vaccine. It uses a virus vector called the chimp adenovirus. It also is 2 doses. And this was paused after a case of what seems to be transverse myelitis, and that followed a case of what turned out to be, I believe, multiple sclerosis. At least that's the information that's available. Now, this trial has been resumed in the UK. It's been resumed in Brazil and in South Africa. But as you said, just as of yesterday, it's still on pause here in the US. And then the last of the vaccine trials that just got launched today, according to the press releases, is from Johnson & Johnson. This is an adenovirus 26 vaccine. Adenovirus 26 is a type of adenovirus. This has been used to create the Ebola vaccine, which has been approved in Europe. And this opened today. What's interesting about this trial is it's one dose. And this one, other than, in distinction to some of the other ones, doesn't need to be frozen. This one doesn't have that same freezing requirement. So will this get us to where we need to be? You know, we've heard that the FDA will probably send a benchmark of about 50 to 60%, about 50% efficacy. So I don't think, unless these vaccines greatly exceed that these will get us there by themselves. I think behavioral changes, masking, social distancing are a reality and will stay a reality until we can really get, you know, a large proportion of people immunized. And then the question is, how long do they last? But, you know, this is a less mutable virus, as you were alluding to, certainly than influenza. And so I think and it's less mutable, I would say, than HIV as well. And unlike HIV, of course, it doesn't have that same, you know, targeting of the immune response as its primary target. So I do have more optimism for vaccine here than I did for, you know, I think we'll get there quicker than we did for HIV, which obviously is decades in the running. So.
Okay, so it looks like there are a lot of good questions coming in, and it looks like we can now do these questions for part of the 7, for the remaining half an hour. And actually, just related to what you asked, which vaccine would you feel comfortable getting? That's a hard one to know, though, right now, I think.
Yeah, hard to know. I mean, the adenovirus, the Ad26 one, has been in many tens of thousands of people for other diseases, so that at least the vector has been studied before for HIV vaccines, for Ebola vaccines, as an example. But yeah, we just need to know more. We just need to know more. Monica, maybe I'll ask you.
Oh, yeah.
This is the question that everyone wants to know the answer to. As Americans, why is it so difficult for us to follow a guidance to wear a mask, social distance? Can you give us the answer?
I cannot, but I can actually. I think there's like 3 reasons. One is that I think that the CDC messaged about masking maybe in a way that confused the public at the beginning, because on April 3rd, when they put out their guidelines, they said, wear a mask to protect others. And actually the website still says that. However, and that was based on the fact what we were talking about before, that you can shed the virus at high rates from your nose and mouth when you're asymptomatic. And so wearing that mask protects others. But there had been plenty of data from other viruses that people wear masks to protect themselves from respiratory viruses. I mean, this is true of influenza or other viruses. And so it could have been that message didn't feel like doing your civic duty. That may not have appealed to where we are right now in this country in terms of making decisions. And I think saying that masks protect you and protect others is a more powerful message. And that is how we changed our guidelines in San Francisco and California both. So both of our, both the state and city now say very loud and clear, it protects both. I remember the day that masks were messaged on April 3rd really well. And I think that because the president messaged it from the CDC, because he was holding daily press conferences, and he said, well, it's totally voluntary. I'm not going to wear it. What if I had to meet a king or a queen with this mask? And I'm not going to wear it. And he indeed has not actually modeled that behavior. And I think modeling behavior is really key. I think that any study of asking people to change behavior has shown that modeling of behavior by public health officials and leaders really help the populace get on board with a change. And this is quite a change for us. So I think modeling has been lacking. And then finally, I think that I think that there has been mask provision is also really helpful. Like Taiwan provided masks to their populace. They actually started on March 6th, mass producing masks and just provide them. And I think that provision, I think there was a plan actually that the government was going to provide masks to the American population, but then they didn't. I think that money went to the defense industry, but that from the CARES Act, but that very thing where you get in the mail something that like you're asked to do for a whole year, even if they're gross masks and you're not going to wear them, it's still like, it's sort of a incredible message. And so I think being in HIV, you and I both know that behavior is a big part of HIV, and harm reduction behavior means that you model it and you provide it and you make it easy. And there are ways that we could have done this differently, I think, in this country, because I don't think any other country, I've been told that the Netherlands, there's more of a fight around it, but I don't think I can think of another example where there's been such a conflicted relationship about masks. And you know, I wanted to ask you that, do you think remdesivir and dexamethasone, you were talking about things need to be used in combination, but do you use right now for severely ill patients, do you use both? I mean, at this point, even without like data being put together, given that they're different kind of things, would you just go ahead and use both remdesivir and dexamethasone for severely ill patients?
Yeah, you know, that's a question I knew the answer to in terms of what should be done. I can tell you my thoughts on it. So for moderate disease, no. For moderate disease, if you're not on supplemental oxygen, if your O2 sat is over 94%, in the recovery trial, the trial that really showed us that dexamethasone works, it worked in people who were on oxygen. Either they were on some amount of supplemental oxygen or they were mechanically ventilated. In the group, and all these people were hospitalized in the UK, in the group that was not on oxygen, there was no benefit at all to dexamethasone, and it actually might have been harmful. At least the recovery rate ratio looked like it was going in the wrong direction. So what I like to make sure people realize is dexamethasone is not for people who are ambulatory, no outpatients. You know, if you have another reason for steroids, fine, but not for their COVID. And similarly for moderate disease, not yet on oxygen, I wouldn't give dex. Now, once they're on oxygen, you know, we don't have a lot of data. In recovery, the trial that showed dexamethasone's effectiveness, there was really just a handful of people on remdesivir. It just wasn't available at the time. And so we don't have data on the combination. And so they do work, as you said, completely differently. Remdesivir an antiviral, dexamethasone an anti-inflammatory. I would say that in people on supplemental oxygen, it is reasonable to give both, understanding that we don't know that they work together, or we just don't have the data to be confident. Theoretically, why might you want to give it? You know that you resort to theory when you just don't have a clinical trials answer. Theoretically, we know from influenza, at least, if you give steroids, the virus just persists longer, and there is some evidence for greater rates of complication. So the idea here would be the antiviral would, at least in early severe disease, there's still some viral replication. The antiviral would keep that under control while the inflammation was being dealt with the dexamethasone. So that's a theoretic reason to use them together. In terms of combination therapies to keep your eye on, there is a randomized trial of a different anti-inflammatory, a JAK kinase inhibitor called baricitinib. And the NIH ran a large trial. It's called ACT-2, following ACT-1. ACT-1 was the remdesivir study. And there are data that will come out soon on, or there was at least a mention, a press release that there will be data coming on the combination of that anti-inflammatory, baricitinib, with remdesivir, and that's compared to remdesivir alone. So that's the kind of, you know, comparative trial that allows you to figure out if a combination works. So that's my answer on, you know, we do use it at times together, but we don't have good data, you know, to be sure that we're doing the right thing.
That makes sense. Thank you.
I saw a question that has to do with Antiretrovirals. Now, as you also said, we're really HIV people at heart that have been repurposed to COVID. Um, uh, what do you think about a couple of things about HIV and COVID? First, do you think people with HIV are more likely to get severe COVID, less likely, or just kind of neutral? And is there anything about the antivirals that might protect people? You know, is tenofovir close enough to remdesivir? Not just that they have the last 3 letters, but are they close enough that they might actually, that tenofovir or any other antiviral might help against COVID?
Yes, I mean, I think that, I think the short answer is there's been 3 bigger studies about how HIV affects COVID, either susceptibility or outcomes, and it doesn't look like HIV, at least in the US and Europe, has an effect either way, meaning there was a veterans aging cohort study that was shown at age 2020, then there was a Madrid study published in Annals of Internal Medicine, and both of those studies, like 236 co-infected and 253 co-infected people respectively, didn't look like HIV made COVID worse or had more susceptibility. In the Madrid study, in the Spain study, people who were on TDF seemed to have less severe outcomes. But, you know, unlike in the US, we use TAF very routinely, and there was no difference with outcomes with TAF. And why you'd be put on TDF is likely because you're healthier and you have less renal insufficiency or bone insufficiency. And so it could be that was a channeling bias. And I don't think that proved anything about TDF, though. To admit, you know, TDF does, at least in vitro, look like it would inhibit the RNA-dependent RNA polymerase of SARS-CoV-2, just like remdesivir would. But we also thought that lopinavir, ritonavir would inhibit the SARS-CoV-2 protease like HIV protease, and at least the trials didn't work out. On the other hand, I wish we had a trial on TDF and SARS-CoV-2. I have to say, I wish that had been another arm. And then in terms of one other study, in Western Cape Town, which is now published in CID, it did look like HIV had a little bit of an effect on COVID, meaning more severe outcomes or higher mortality, but it wasn't very high compared to all the traditional risk factors for COVID, like age and diabetes and hypertension and everything else. So it wasn't very significant. So the answer that's sort of come up, and I think there's going to be a special edition of the AIDS Journal on October 1st, because I was looking ahead and Mike Sad wrote the introduction. And I think this also reflects New England Journal Watches that essentially in the US and Europe, HIV doesn't seem to make a difference, which is good, because I think people were nervous that it would may have more severe outcomes. And in fact, I have had patients say to me, I'm really adherent to my therapy because I actually think it helps. And I do not discourage them from doing that. Just because, I mean, if it helps adherence to be in a time of COVID, then why not? And so I think it probably doesn't make it worse, but why not stay on your antiretroviral therapy?
Yeah, you know, though, I totally agree. And the one thing I would add is one thing we shouldn't ever forget is our patients with HIV have a number of other comorbidities that we should probably be thinking really concretely about. Pretty much every trial that's looked at HIV and COVID has shown that people who get COVID with HIV often have comorbidities. And we had about close to 50 people at Mass General who have HIV and who got COVID. And almost 90% of them had some other comorbidity, not HIV, that put them at really substantial risk for COVID, severe COVID. They had either obesity or lung disease or worked or lived in a congregate setting. So, so yeah, that in my mind is probably the biggest thing to be thinking about with our patients. Is not just their HIV, but what else do they have? So.
Yes, I think that's so fair. And we used to say that about cardiovascular disease. Think about the diabetes and the smoking and everything else, and control that. I don't know if you hate being asked this, actually, but I have to. Have there been any new developments regarding the use of azithromycin or hydroxychloroquine? And the reason that I ask is people do say, well, okay, well, what about outpatients? And we were saying, oh, there's so much asymptomatic and mild infection, but what if you're kind of on that edge? Is there anything you could do? You just said dexamethasone we can't give to an outpatient who isn't intubated. So anything else that you can think of for outpatients that's even being examined?
Yeah, you know, I think the focus should be on more outpatient studies. A lot of those early trials April, May, June were really on very, very severely ill patients. That's when we got the ACT study. That's when we got the recovery study. That's when we got some of these tocilizumab studies. There were several randomized studies with hydroxychloroquine in hospitalized patients that really definitively, in my mind, settled the question that hydroxychloroquine does not work in hospitalized patients, the recovery trial being one of them that had a hydroxychloroquine group. There was a trial in Brazil that pretty much settled that hydroxychloroquine plus azithro really didn't look any better than standard of care, no hydroxy, no azithromycin. So the IDSA and NIH have really come out saying, no, for hospitalized patients, this is not going to be beneficial. What do we know about earlier stages? If this is an antiviral, and there's a lot of debate now as to whether it really is, we think antivirals work earlier than later. The post-exposure prophylaxis trial that was done did not support any benefit for hydroxychloroquine. There were limitations to that trial, so I would acknowledge that. And then there are a couple of early treatment trials also, one in Spain, for example, that really didn't show a benefit of hydroxychloroquine in milder disease, and also one in the US that didn't show any benefit. So, I would say that really we don't have any trials that show us that this particular drug or combination, hydroxychloroquine azithro, really works. One of our friends, Rajesh, Badimo, sometimes compares hydroxychloroquine to Hydra. The heads keep cutting off and they just keep growing back. I think in hospitalized patients, that's a settled issue. And in outpatients, the trials I've seen to date really haven't supported a benefit. They do have some limitations. Now, what else can we do? I think that's where a lot of the focus is right now. That Lilly antibody that I was talking about, that's an outpatient study that the ACTG, the AIDS Clinical Trials Group, is doing. Really important study to know the answer to. Can antibodies really help prevent hospitalization? There are other things that will be studied. There's an oral drug called EIDD-2801. This is kind of another RNA polymerase inhibitor. That's another example of a drug that I think would really be interesting to study in early disease. So I think we don't have anything right now for mild disease, but I think we'll get there if we do these kind of studies. One intriguing idea that I'd like people to think about is we know now that people with HIV who are treated, we prevent transmission. There's no doubt that treatment equals prevention in HIV. Wouldn't it be interesting to know that whether or not treatment of early COVID, whether that prevents transmission? We talked about, will a vaccine get us there? It may not get us there in and of itself. I think we'll need behavioral changes, but if we could find a treatment that also prevents transmission, then you've got a multi-pronged approach. And so that's a really interesting idea. There are some people on this call who know a lot about treatment and prevention, and it'd be interesting to see where we are with COVID in a year.
Yeah.
This is a tough one, just to put it out there. How do you counsel a patient with severe COVID-19 who many months ago was critically ill in an intensive care unit and now has post-COVID symptoms and also has other immunocompromising conditions, rheumatoid arthritis, and needs biologics that might be immunosuppressive? I think they're not only asking about the post-COVID symptoms, but just this worry about the immunosuppressive agents. What are your thoughts on that and risk of COVID?
I actually have been really interested that biologics in and of themselves don't seem to be risk factors for, even if they're immunosuppressive for this particular virus, at least it's not come out so much. I think things like, renal insufficiency being an immunocompromising condition or other immunocompromising conditions, but HIV, maybe the reason HIV doesn't matter as much is maybe the immune system in a way contributes to the pathology, viral pathogenesis at the beginning. So I think that people should definitely be treated for their conditions that they have with biologics. Chemotherapy, which is a very blunt, kind of profound immunosuppressing, has been associated with COVID outcomes, more severe outcomes. So I think chemotherapy is different than targeted biologics. So I would say, please treat the rheumatoid arthritis. And then also it could be that there is some immunity after COVID for this person while we're waiting for a vaccine. Masks are going to be essential to prevent also further transmission and social distancing to make sure that there's not re-exposure.
I think you implied this, but someone who's had COVID should absolutely continue to wear a mask.
Yes, but I think that does, come to the question of the post syndrome, which that's hard to discuss because I think that we need better studies that like compare the severity of disease at the beginning and what degree of severity of disease is associated with post symptoms. But I think there is a symptom though, a syndrome that we have to elucidate better. We had stopped our last talk with ivermectin because I remember Wendy Armstrong actually emailed me after and said, because I had said save ivermectin for the worms, and she had said she also thinks they should be saved for the worms. I do actually think they should be saved for the worms, but you could tell me if only because I remember there was this compound that. Minoxidil that was used for hair loss. It wasn't minoxidil, but there's something for hair growth, Finiqua, but it was also really needed for like neglected tropical diseases. And then we ran out of, what was needed for neglected tropical diseases because of other uses. And so I wanted to ask your opinion if we could come back to ivermectin because we had discussed it before and not been so convinced, but it looks like this question is specifically that some doctors and hospitals, and it was specifically labeled in Florida, are giving ivermectin. And what's your opinion?
Yeah, maybe I'll take both ivermectin again, and actually someone also asked about famotidine, so maybe I'll try to tackle it. So, ivermectin, like a lot of drugs, you just really can't, as best we know, you just can't get enough into your system to have any real effect on COVID-19. So let me give you the example of lopinavir ritonavir. Lopinavir ritonavir has been thought about for COVID because at least there are some studies that suggested it might have an effect against coronaviruses. It was studied in SARS and with historical controls. It's being studied in MERS. But all the data for lopinavir ritonavir, and there's now pretty good data, actually quite good data, including again from the recovery trial, saying that lopinavir ritonavir does not treat COVID, does not have a benefit. One of my very favorite studies is a study from Austria where they looked at drug levels with lopinavir ritonavir. How much can you get if you give a standard dose of lopinavir ritonavir? And it turned out you would have to take something like 60 to 120 pills of lopinavir ritonavir per day to get your drug levels up to where you need to inhibit the SARS-CoV-2.
I said that you would throw it up so much that you
exactly.
Me. That's terrible. That's
everyone who's ever either tasted and or had a patient take lopinavir ritonavir knows that's just not going to happen. Now, as far as ivermectin and famotidine, I think it's kind of we're in the same boat that you just can't get enough of these drugs really to have an impact on the SARS-CoV-2. There are single-arm studies both for famotidine and ivermectin, but they're just not very definitive. In fact, they're not convincing enough to be using. And so I would caution people, just as we've gotten away from hydroxychloroquine, gotten away from hydroxychloroquine plus azithromycin as we've gotten more data, I would urge people to stay away from ivermectin and to stay away from famotidine until there's something more than what we've got right now. And I really am skeptical about both those drugs.
But we do need them for other uses. So
we do need them for other uses.
You need the helminths to be combated. I think that I'm looking at the questions and I'm wondering if I could just address the one about food, because I agree that these fomites, I actually was very relieved when fomites became less, went away in terms of a serious concern, because I do think that if people stay distanced, the question is actually about serving food, that you don't want to share food. And I think the time of sharing food is gone for a while. But I think that serving food from a same place with a clean spoon, there's no reason to think that we are, by giving people food from the same place, as long as we keep stay distance that we can, that wouldn't be a safe activity. So I think that's fine to sort of food family style. I mean, actually, if I can bring up that, there's been some very good studies recently about the activities that are considered safe or not safe. And it's hard. I mean, it was a CDC study on September 11th from the MMWR about activities that may be more associated with symptomatic COVID. And it seems like dining would be, but they didn't distinguish between outdoor and indoor dining. So sometimes that was taken out of context because I think we have to think about ventilation when we do it. But any place that you can mask, I think is a place where I feel safe. These are activities that are safe, and if you can't mask, then being outside and staying away is very helpful. And the reason I'm saying this so forcefully is I think they should open the museums in San Francisco, which they're going to do in about 2 weeks, and it's going to be masked, and it's going to be less capability, and there's ventilation, but I think it's a place where you can stay masked.
Yeah, no, I would say the same. And there are more and more data that we all know about hospital settings, and the fact that since universal masking has been in place, really hospital rates of transmission have just fallen. And so I feel more comfortable. I like to say that I feel more comfortable coming to work than I do going to the grocery store, because at work, most people have their masks, where they should, whereas at the grocery store, it's kind of hit and miss. So yeah, no, I feel, I think there was a question about N95s, and I think masks are really, the fact that we see so little transmission in hospitals now with universal masking is just a testament to what they're doing.
Yes. I think I totally agree. And healthcare workers have been going to work every day since March 1st, really, since it started. And luckily with the universal masking, right, also symptomatic disease is so down. So I think Dr. Redfield said just a week ago today, the statement was masking is as important as a vaccine, or at least until we get to the vaccine. And I think he was completely right to say that is, even when we get to a vaccine, like you were indicating before, we may need more than one dose. So, or it's going to take a while for the population to have enough immunity. So we're going to be masking for a while. So I think make it comfortable and something that you want to do.
Yeah. One person did ask about the flu vaccine and COVID. Certainly, flu vaccine is important now more than ever. And I think I'm rushing out to get my flu vaccine and telling my patients to do the same. There have been drops in flu transmission in parts of the world where flu has been circulating, probably because of masking and social distancing. But that's not to say we should absolutely not let our guard down, because we just don't know enough about having the two together, and there's all sorts of issues in terms of distinguishing them. And so I think someone was asking, would those afford any protection against COVID? Not against COVID per se, they're just two different, the viruses are too different, but just some of the complications I think are really critical. So.
Yes, I think this is now the year to do 100% flu shot, and I'm actually rubbing my shoulder because I got it yesterday, and it doesn't hurt. It really doesn't, and I didn't get the flu, but just a little Tylenol. But it's very good to. I think this is the year for flu, but I think you're absolutely right that the masking may end up, having a less virulent flu season, which would be great because we need a little break. But you can't.
Great.
I think that is pretty much it. And I did get you for your birthday, which is in a couple of days, something where you can mask and go in and actually, so I'm revealing this to the world when your birthday is, but where I feel perfectly safe with you masking in Boston and going into this setting. So you'll see. But I think it's time to start wearing masks and looking at things close up, like art and books and stuff. So you can guess where I am.
Great. Well.
And then call your father if you haven't, because it's our mutual father's birthday today. I'm sure knowing you've already called him.
Special day for all sorts of occasions,
Yeah.
all sorts of reasons. So I think we're supposed to end up with a slide that Jose may be putting up even as we speak, and then we'll go call our parents. So here we go. To view upcoming and on-demand activities and IAS-USA activities, including these dialogues, webinars, as well as virtual courses, here's your link. And if you have comments, and we really mean this, please email the links, the email addresses there. I know the folks at IAS-USA really want to know what you're interested in and what you would find most useful. So I think with that, we'll call it a night, and thank you all.
Okay, talk to you soon.